everyone. I'm Lisa Bell from Respiratory Therapy Department. I'm the lead therapist, and typically we do an in-service, in-person, going over oxygen devices, BiPAPs, AVAPs, and ventilator information. But with COVID, we're doing video presentations. So I'm just gonna go over everything pretty briefly and try to hit the highlights of things that I think that ICU nurses really need to know. So starting with oxygen devices, regular nasal cannula, we run it at 1 to 6 liters per minute. It gives an FiO2 content of 24% to 44. We don't run higher than 6 liters per minute with a regular nasal cannula device. We can humidify it with a bubbler humidifier. We typically like to do that 4 liters and above, so 4 to 6 liters, because it's more patient comfort level is greater with humidity when the flow rates are a little higher. It doesn't have to be, but it's preferred. If you need a device that's requiring the patient to have higher levels of oxygen than the 6 liters and you're not able to maintain saturation, an O2 saturation of 90% or higher, 90% is our cutoff, then you need to go to a different device. A couple different options that you have is you could go to a Venturi device, and this gives a range anywhere from 24% to 50%, so it's a little bit higher than the nasal cannula. We also use a Venturi mask for patients that maybe are having some nose bleeding, maybe they're a mouth breather, or maybe we want to give a specific content of oxygen, and this is a really good way to control, give a controlled FiO2. So the setup is based on the numbers. So the higher numbers, 35 to 50, are white, and we use the white adapter. And then the oxygen tubing is hooked, and it gives you a coordinating flow rate for liter per minute for what you're going to set your actual flow meter at. The smaller concentrations are in green, and those are 24 to 30%. And then you'd use the green adapter to coordinate, and it gives the correlating liter per minute flow rate for that. That's really good for a lot of times COPDers, because you want to be really specific with not giving them too much oxygen, and we can coordinate content with that. Another device that gives higher concentrations of oxygen is a rebreather mask. Typically, it'll be referred to as 100% non-rebreather. We run it at 15 liters always, never lower than that. You can plug it in to your flow meter. Turn it up to 15, and then I hold my fingers over this valve, because when you place it on patient, you want to make sure it's fully inflated, so you're delivering 100% oxygen here and your reservoir is full. This is the closest if the fit is good and your flow rate is at 15 and your bag is full, you're delivering as close to 100% as we can possibly. So that's the highest device that we have for oxygen concentration. Another option, this is really great, this is the high flow nasal cannula. You guys see this all the time. We put a sticker on it because we, respiratory therapy are the ones to titrate this because of the higher levels of oxygen, FiO2. We fill it with sterile water for humidification. It's a cool humidified system. It differs from a regular cannula in the tubing size, which is it's larger bore, and the actual cannula itself is much bigger, so it delivers the higher levels of oxygen concentration. We never put any extension tubing on the Salter high flow cannula. A couple of reasons is it messes with the actually delivery of the concentration of oxygen to the patient. And if your patient is requiring higher levels of oxygen, we don't want them getting up, going to the bathroom, doing a lot of exertion. It runs at 6 liters to 15 liters, and it always needs to be humidified. It kind of picks up where this one takes off. This one goes up to 6, and if you're going to keep them on nasal cannula, then you go to the Salter. The 2 mask devices, your non-rebreather and your Venturi, are never humidified. We don't ever humidify the masks. They're not meant for that. Just the 2 cannulas. Real quick, I want to go over the new ambu bags. We've had a lot of issues with COVID this year and making sure that we have a filtration system in place with these. The new ones that we've ordered that are going to be corporate wide come with the filter right in the bag, so we don't have to worry about adding anything extra. It goes between mask, patient, your filter, and your bag. That's how it works. And then after the patient's intubated, the mask can be removed and you can bag the patient like that with the filter in place. Heated high flow nasal cannula is the last system. It looks a little bit intimidating, but it's super convenient, super easy to use, and it's an excellent choice for patients that are requiring high levels of flow with or without high levels of oxygen. We've got a concentrator, oxygen concentrator on it, so we can deliver a precise amount of oxygen. And then the flow rates go anywhere from 20 to 60%. We typically run 30 to 50 when we're running this, and we can run high levels of oxygen up to 100%. So it's a high oxygen delivery system, but we have a lot of flexibility with it. It's always humidified and it's always heated because the levels of flow that this system utilizes has to be the moist heat. So that's how we utilize it. The cannula goes on the end here. We have a few different sizes, small, medium, large. They're very flexible and soft. They've got a little clip in this system that goes around the patient's neck, and then we clip it so that it can stay in place. It's soft, flexible, the patients like it. It's very comfortable. It's a really good option for COPDers, asthma, pre-vent, post-vent, patients that want to take a break from the BiPAP that we're having a hard time with their respiratory status and oxygenation status. We can give them breaks. They can eat with this because it's a nasal cannula. A lot of times they'll wear this one during the day. They'll wear BiPAP at night. It's a really great option for them. It works well. This is our V60. We use this for BiPAP and AVAPs. Positive pressure, non-invasive ventilation. I'm going to turn it on. It's going to alarm. So basically, for your guys' purposes, when you see this in action, you can see that the ST mode, it's in a BiPAP mode. So it'll give you a pressure on an IPAP and an EPAP pressure. We set the FiO2 and the I time. We don't set a rate with BiPAP. It's just basically it's a continuous positive pressure type of non-invasive ventilation. The silence mode is up here. If you're taking the patient on and off, that's going to trip with the alarm. You can pop the silence. If the patient's going to take a break from BiPAP, you can put it into standby, and basically that creates a holding mode, and it'll sit and it'll wait for a patient reconnect. So if you're taking a break and then you want to place patient back on BiPAP, when you put them back on, the system will automatically, I'm going to show you with the hand, will sense that seal, and it should go ahead and initiate ventilation again. And you'll know that because you'll hear it and you'll see your numbers. So standby is important. Your silence alarm is important, and then your alarm reset so that if you place the patient back on and you want to reset your alarms, you can hit that. So if you've got a patient that you've put in AVAPS mode, and I always forget this, it's average volume assured pressure support. That's what the AVAPS stands for. Basically what we do here is we set everything that we would for a vented patient, but it's without the endotracheal tube, so it's non-invasive ventilation really. We use a tidal volume at 8 cc's per kilogram of ideal body weight, just like we would for our vent settings. We use an EPAP. We use a high and low pressure, and the patient breathes between those two pressures at their comfort level to achieve the target tidal volume that we've set. We usually set a rate of 16, just like we would for a starting ventilator patient. And then of course we can dial in whatever oxygen content we want, and then an I time. So this is for patients that maybe have recently been extubated and they require more support, or they require more support than BiPAP patient. The other thing to remember with BiPAP and AVAPS both, we never can use it on patients that are double restraint. They have to be able to at least lift one hand to remove the mask. And also obtunded patients, if they're not able to have the faculties or the mental status to be able to take that mask off, we cannot use it. In the policy, there is something that states, like primarily for ER, or if a patient's mental status is changing, we can put them on for like a 30-minute time frame, get a set of blood gases, look to see if we're improving. If not, this is not the choice for us. The patient would need to be evaluated and then probably intubated and put on the ventilator. So I brought the 980 ventilator. This is what we're primarily going to be running. Our 840s are kind of phasing out. We're slowly getting rid of those and retiring the ones that are older. And pretty soon, probably in the next like 3 years, we're going to be running all 980 ventilators. A couple of things that I wanted to touch on is if you have a vented patient and you're going for transport, respiratory therapy, we require for our policy, when we place them on the transport vent, we do it for a 15-minute time frame. That gives us enough time to make sure that the patient's going to be able to tolerate that different ventilator. We put them on the same settings, but the vents are different, and that way we can see if there's any issues before we actually remove the patient from ICU setting and take them on a road trip. So if you know you're going to be taking the patient for a CT or MRI, give us at least 15 minutes. We can get that, that vent set up. The other thing is with vents, if you're having some problems, if your saturation is low and you're hitting your 100%, your 2-minute 100% oxygen, unless it's something that you've been suctioning or you've been moving that patient and they're desatting and there's a specific reason why they're desatting, you want to give them a little time to recover. Once that 2 minutes is up, if their oxygen starts coming back up, we're good. If it's not, give a call to your respiratory therapist right away. We need to come up, we need to evaluate the situation, we need to maybe increase that oxygen content. It may require a PEEP increase, it may require a call to the intensivist. I mean, if the patient's not doing well, or there's multiple reasons that could happen, but we always need that call. We need to come up and be able to troubleshoot and evaluate for ourselves. Vent settings, the other thing that I wanna, basically it's full support or weaning modes are the two modes that we use. We use different things for full support, assist control. We also use the VC Plus mode. It has an eye time. They're similar, they're controlled form of ventilation. For weaning, we will use primarily pressure support. Sometimes we use tube compensation. It just depends on the patient, whatever they respond to the best. Every morning we do a wean assessment. We look at all the hemodynamics. We look at respiratory status. We look at muscle strength. If everything looks good as far as if they're hemodynamically stable and the vent settings are not, they have to be within certain parameters, we will assess, and then we go from there as to whether we think they'll tolerate the weaning process. The biggest thing for ICU nursing and respiratory is a teamwork approach, and we need to know, for us to come in and try to do a set of parameters or even do an assessment, if they're on higher levels of sedation, it doesn't do us any good because the patient's ultimately gonna fail. So we like to kind of coordinate that to see what levels of sedation the patient's on, what nursing thinks, if they think they're a candidate for the wean that morning, if there's been any issues during the night or anything that morning that we need to know about. That way we can get a heads up and we can talk about it and see. Often they maybe are scheduled for a procedure or there's something else going on or even dialysis, and you know, you guys will say, let's hold off on the wean. There's no point in doing it now. I want to keep the patient comfortable. Those are all things that need to be communicated to us so that we can work together and provide the best care for the patient, really. So that's a biggie for me. The settings, we mostly control the settings. You'll see for a C here, that's controlled ventilation. That means that the vent is initiating that breath or delivering that breath. Let's see. I'm gonna pop it into a spontaneous mode. And you'll see an S there. So that just means that that's a patient-initiated breath. And that'll give you a little heads up that they're in a spontaneous mode of ventilation. As well as down here, you can see spontaneous pressure support. You'll be able to tell that way too. Ultimately, respiratory therapy should be communicating to whoever's taking care of that patient nursing-wise on what we're doing too, so everybody's aware we're all on the same page. So for vent alerts, I'm going to do a disconnect so you can see a high alert alarm. You can hear the tone and it should flash across there too to let you know. There's always also a log in there to tell you that you can track what alarms went off. So like if you call respiratory and it's not doing something then when they come up, they can look through that log, they can see what alarms were tripped, and we can kind of try to determine like what happened or why that was happening. Sometimes it's just a quick, that alarm is more like a caution alert. That means that maybe they set off a high pressure, maybe they were interrupting the breath and doing a little bit of like stacking. That isn't really a critical alarm. It's just something to kind of take note that maybe if they're tripping that often, maybe their respiratory rate's a little high, maybe they require some sedation at that point. But the big one is that red, that high caution, high alert, because it could be a disconnect, it could be more serious. Some reasons for that high pressure alarm: secretions in the tube, the patient maybe need to be suctioned. Maybe there's an obstruction or a kink in the tube. Maybe the ET tube is kinked. I'm trying to think of what else would trigger that high pressure. Patient coughing against the tube. The biggie is if you have a low pressure alarm, that's probably gonna be a disconnect, and that does happen too. A lot of times with your trach patients, it comes off often, and constantly popping off. That's gonna be a high critical alarm, letting you know the patient is disconnected from the vent. That's pretty much all I have for now. If you guys have any questions, the main thing is always contact Respiratory. When you go in your phone and you look under My Units, your therapist that is assigned to that unit is the one that you can contact. In doubt, if you get into trouble and you can't find them, any therapist that has the green dot, give them a call, they'll help you. They can assist you in getting you to the right therapist.